I had ITP study open where the Romiplostim, it was a phase 3 study looking at the efficacy of Romiplostim in children with immune thrombocytopenic purpura. And I got very comfortable with that drug. And as I was doing this clinical trial, a lot of data came out about mimetics and its role on the hematopoietic stem cells. So Romiplostim is one of the mimetic thrombopoietin agonists who have been used, were simultaneously being studied in aplastic anemia patients. And the mimetic, which was much advanced, was L-thrombopeg. And Romiplostim, and partly because L-thrombopeg is more oral drug, while Romiplostim is an injectable formulation. And so there were a lot of studies which suggested that mimetics actually induce the hematopoietic stem cells, and they cause the expansion of the hematopoietic stem cell pool. And there was an interesting study which came out from NIH, National Institute of Health, in adults who were treated with L-thrombopeg, and they were relapsed and refractory aplastic anemia patients. So that was very interesting. So I was kind of simultaneously studying this drug a lot, or particularly TPO receptor agonist or drugs. And around that time, we had a couple of patients with aplastic anemia which came up, and there were some circumstances where we couldn't offer them a standard of care. Families refused the medical standard of care, which is immunosuppressive therapy, and they did not have a matched sibling or even matched unrelated donor. So we kind of offered Romiplostim. We could get the drug even though it wasn't approved for this particular indication. And to our surprise, our first patient responded very well. And then the second patient responded, and this third patient, who was initially diagnosed to have aplastic anemia, turned out to be actually myelodysplastic syndrome. And there were a lot of back and forth about this patient. Took a long time for diagnosis, but there was again significant limitations about what family wanted. And that's when we offered this therapy. This wasn't like completely random, because there were some studies, particularly in patients with MDS, low risk MDS, and so we just thought of giving a shot with that, and that's how this patient was treated. But after first couple of patients, I realized that this may be working very well, so I proposed a observational study. And since the drug was, the manufacturer is Amgen, I reached out to Amgen and I asked for the funding, which took a year or two to get the funding. But my initial observational study I started and then converted it into a pilot interventional trial. Yeah, so this study particularly, what I have presented in this poster, has two components. One is the observational component, where we kind of treated the patients based on, if they were unable to get the standard of care. We did not discourage standard of care for any patient. It was just patient's choice. And so subsequently, once I got the funding, I converted that into interventional study. And so that's how the study has two arms, the prospective observational arm and the interventional arm. The difference really is we gave the drug for free because we got it from Amgen. And so the current poster tells about what are our preliminary results of those studies, that population. Yeah, so it was interesting that we have a phenomenally high success rate. Now, some of the patients, as I mentioned, were treated without standard of care, which is immunosuppressive therapy, and some patients were treated with immunosuppressive therapy. And almost 70% of the patients have complete response rate. And what I mean by complete response is that we use the definition used by North American Aplastic Anemia group. There was a paper published by NAPAC study team, and we used that criteria about hemoglobin more than 10 grams, platelets more than 100, and the absolute neutrophil count more than 1500. And these patients should not receive any transfusions. So they should be platelet and red cell transfusion free. And so we were very surprised that, we have almost 70% of the patients who responded, and they stayed in complete remission. I mean, the longest follow-up I have is up to 6 years. And what we generally worry in patients with aplastic anemia or myelodysplastic syndrome is that you tend to worry about evolution into malignancy, like a clonal evolution, such as leukemia or PNH clones. And we manage them, we monitored them very, very closely, because I was very worried. I was using a drug which wasn't approved in pediatrics. And so we haven't had any evolution, clonal evolution in this particular group. And so that was impressive. The other thing we could get out of this study is that what is the regimen we can use for Romiplostim? Like if we were to use, because what regimen we have is from ITP population, which is starting at a very low dose and then increase by 1 to 2 micrograms, like start at a lower dose at 1 microgram and increase with 1 microgram per kilogram per week. And so we felt that that is not a right regimen for aplastics or MDS, because these patients are pretty sick. And so you really, really need to start the therapy which can, increase the counts quickly. And so we decided that we will use the adult regimen which they have used. And so we started with 5 micrograms per kilogram per week. Now in adult population, they increased the dosing pretty fast with 5 microgram per kilogram per week. We were a little bit anxious to do that, so we did like 2.5 microgram per kilogram. And we decided to go as high as 20 microgram per kilogram because there is an urgency to get the counts back, And so I'm very happy that now we know what regimen actually could work. The other part of this study is that obviously when you do something, you look, most important is a safety. Efficacy wasn't really the primary point for us. So safety, we did not see the clonal evolution. The other worry we always have with this mimetics is that can it cause some of the side effects like bone marrow fibrosis? Or thrombocytosis or venous thromboembolism, and we actually did not see that. In fact, I personally was monitoring the blood smears very carefully, because if you have bone marrow fibrosis, you tend to develop some teardrop cells, and we did not see that. And our lab was also alerted, because we have worked very closely with the pathologist to look for the teardrop cells. So I think even though it is a mimetic, it's slightly different than how the L-thrombopeg works, because in L-thrombopeg studies there have been reports about the bone marrow fibrosis or liver enzyme elevation. I did not see even liver enzyme elevation in this population. And so I feel that there is definitely downstream effects might be different between these two medications. And so my next direction is that I think I feel reasonably comfortable about safety. We just, our paper has been just accepted for Journal of Pediatric Hemonc. So community can read about our paper, but the bone marrow cellularity, what we assume, after the treatment has been impressive as well. And so my next direction really is to conduct a phase 2 trial, because one needs to be extremely careful with the single center study, especially if you have so much positive results. So there is a lot of reporting bias or center specific biases which play a role in those cases. And so I want to make sure that the results could be replicative in future in a multi-center study. And so I'm currently, I have proposed a phase 2 study. We are working to seek funding for that study. It is important to note that for Romiplostim, there is black box warning for the MDS patients not to use this, basically not to use Romiplostim because of the risk of leukemic clone development of leukemia or other cancer predisposing clones. I don't want this message also in the community to use this in MDS patient. Our MDS patient probably was low risk because there were no cytogenetic abnormalities or molecular abnormalities which we could come up with. And so I think I want to be still caution people that, okay, when you are considering, make sure you consider carefully, like it should be patient specific. In my phase 2 study, which we have proposed right now, there are 2 arms. And so one arm is for relapsed and refractory aplastic anemia, and the other arm is for newly diagnosed aplastic anemia. And in that arm, we will be using the standard of care and add the Romiplostim. So this study, this arm may look more or less like L-Thrombopoietin study, which was conducted, just the addition of L-Thrombopoietin. With regards to MDS, I think I will be using, I plan to use for MDS patients and just to see how it responds, but those patients are extremely rare, and that's why we haven't included that population in our phase 2 study.